So, how do recent systemic approvals influence treatment selection for patients with psoriatic disease? I focused my attention on bimekizumab and deucravacitinib as new drug approval. Let's start with bime. This is a slide showing high levels of complete skin clearance across studies PASI 100 through week 16. So we have the head-to-head with ustekinumab, head-to in the BVIVID study, head-to-head with placebo in Be Ready, head-to-head with adalimumab in Be Sure, and in the Be Ready trials, the comparison with secukinumab. And the result of these trials are very convincing that the inhibition of both IL-17A and DEF is more effective than only inhibition of IL-17A with secukinumab. And in particular, in this trial, PASI 100 response was reached by 61% of patients treated with bime, compared to 48% of patients treated with secukinumab. And so one of the major claim to bime is the impressive efficacy, also in comparison with the other very effective drug. And these are the data from the last annual meeting, American Academy of Dermatology annual meeting in San Diego, and is bimekizumab efficacy from treatment initiation throughout 4 years in patients with plaque psoriasis. So not only a matter of induction treatment, but also, let's say, long-term efficacy. And again, PASI 100, so skin clearance responses over 4 years. And we have that in total, the PASI 100 response is maintained at year 4 in 64-72% of cases. That is, in my view, high efficacy, drug efficacy. So the curves are stable, are quite stable in the time. And to me, this is a very good result with bime. The other point to be considered is safety. And again, this is another abstract presented in the annual meeting last year with safety and tolerability in moderate to severe plaque psoriasis and 4 years. And is a pooled analysis of 5 different clinical trials, phase 3, phase 3B. And the most common treatment emergers, adverse event, and also adverse event of interest include oral candidiasis, that is overall affecting, let's say, 8-9% of patients receiving the drug for 1 year continuously. And this data is consistent with my experience, because in my experience, the most frequent adverse event of the drug is oral candidiasis. And of course, the prevalence of oral candidiasis is higher in the first year compared to the other years. No active tuberculosis reactivation, and also the figures of inflammatory bowel disease reactivation or new onset of inflammatory bowel disease is very low. And see, okay, this is a patient of my experience that was treated with bimekizumab, and after 2 months had oral candidiasis, symptomatic oral candidiasis. He was treated with oral fluconazole 100 milligram day for 10 days with benefit, with complete clinical remission without stopping, without interruption of bimekizumab.
Can I ask a question?
Of course.
Since many of our psoriasis patients are on statins, and fluconazole is a cytochrome P450 interactor, how do you manage the statin when you're doing 10 days continuously?
Yes, I select terbinafine. I prefer, in these cases, terbinafine 150 milligram per 2 weeks instead of.
But terbinafine is not active against Candida.
Is less active compared to fluconazole, but still active.
So you do 250 for 10 days?
Yeah.
Okay.
Plus topical therapy, topical anti-candidal therapy in association with oral suspension. But I think, in my experience, only the topical for oral candida is not effective alone as a unique treatment. I always associate systemic.
And does it recur? And when you stop it over years, does it reoccur? I mean, you may not have it yet in Europe for years, but we certainly don't in the United States have it in.
Yes, no, not it's not. It's very frequent to have candida, but not recurrent candida, unless there are other risk factors for oral candidiasis, like diabetes not controlled, smoking, and things like that. But in my experience, I have no relapses of candida. It's symptomatic. In most of the patients, symptomatic burning. Some of the patients do not associate candida with the drug, and so do not complain to me that is related to the drug. To advise patient earlier at the starting of the treatment, if they are burning sensation in the oral cavity, to come back to me. Yeah. But is frequent, but manageable to me.
Thank you.
Yeah. And the other, let's say, new drug is deucravacitinib. And these are the data presented in the EDV Congress in Berlin, 2023. And there are 3 years safety and efficacy data. So in this case, we can see PASI 75 response, so not PASI 100, but PASI 75, with continuous deucra treatment from day 1 to 3 years. And you can see that the rate of PASI 75 is 61% at week 16, but tend to increase over time. And 3-year data, we have approximately 76% of response of PASI 75 responders. That is, I think, also interesting and good enough for an oral drug, not biological oral drug. Next. This is PASI 90 response. PASI 90 response we have in 34% of patients as a primary endpoint at week 16, and more than 50% at their 3-year data. So also in these cases, there is an improvement over time of PASI 90 response. And the cumulative adverse event of interest, 2 years and 3 years data. There is the issues of infection, serious infection, including herpes zoster infection. And the rate of serious infection is between 2 and 3 exposure adjusted incidence rate per 100 patients that received the drug for 1 year. And concerning herpes zoster infection is around 1 over 1% of patients. And I think that these are the major infection issues of the deucravacitinib treatment, including viral infection. We can discuss this new drug approval and give me your feedback. What is the place in therapy according to your experience of this drug?
So I think for bimekizumab, admittedly, you have in Europe already an indication in ankylosing spondylitis. We don't have it yet in the United States. I think that bimekizumab is a great addition. It works really incredibly well, and the comparator studies are very strong in psoriasis. It works very, very fast, and the speed is incredible. And also, it's an every 8-week dosing maintenance, at least in the United States it is. And so no IL-17 blocker has it. As you know, I don't know whether if the patients are on the call. I'm a dermatologist and a rheumatologist, so psoriatic arthritis is important for me, and so it's obviously a very attractive drug in a patient who has both psoriasis and pre-PSA, TFA. But it's a very attractive drug, and the fact that it has approval in ankylosing spondylitis makes it highly likely to be effective in axial disease, which, as we know, IL-23 blockers are not. And so I think it's making a big impact. With deucravacitinib, if you mentioned it, I missed it, but in the first pivotal controlled study, it was an active placebo controlled with apremilast. Its safety profile, if anything, was better because apremilast gave diarrhea. It's certainly quite a bit more effective than apremilast.
Thank you very much, Alice. And you mentioned risankizumab as a possible drug that could be impaired by bimekizumab. However, they have different mechanism of action, right? IL-17 versus IL-23.
I get it.
Yeah. And which is the place in therapy, according to your perspective, the difference in place in therapy when you use RISA or IL-23 inhibition versus when you use IL-17 inhibition, so RISA, BIME or other IL-17 inhibitors?
If I'm concerned about psoriatic arthritis or the development of psoriatic arthritis or the family history of, something like that, and they don't have inflammatory bowel disease, IL-17 blocker.
Yeah.
And if somebody wants speed and IL-7, and there's no reason not to do it, I think IL-17 blockers are faster for both in the skin. And then we have no comparator studies in the joints. For if somebody's needle phobic, clearly an IL-23 blocker. Well, not even so clearly now with bimekizumab, but if there's no at all concern about psoriatic arthritis, and you don't really think they're even close to getting it, then it's really a choice between the patient whether speed is more important than let's say fear of candida. In my experience, 20% on IL-17 blockers and bimekizumab in particular, I don't see 20% of patients having oral candidiasis in my population.
Yeah.
In my population has a high skin of color, so maybe it's different. But I don't see that high incidence of candida in my population. It's not zero, but I don't see.
Yeah.
It's for most patients, it's a non-issue. I mean.
Yeah. Thank you. Other insight?
May I?
Yeah.
May I ask?
Yeah.
In Japan, I have experience using bimekizumab for psoriatic patients, especially clinical trials. So unfortunately, 10% to 20% of patients have oral candidiasis in Japan. Yeah, so I think Asian countries, that's why, because I think in Asian country, unfortunately, they don't care oral regular care.
Hygiene.
So that's why probably oral care or uncontrolled oral bacterial or something like that. Probably this will induce oral candidiasis Japanese patient with psoriasis. So that's why I recommend patients to push oral care regularly. So every 3 months or something like that. Yeah, so then most of patients have no oral candidiasis so far. So I think this is very important for Asian patients.
Thank you.
You're actually doing them a favor, because by pointing that out to them, obviously you're preventing gum disease, but there's some issues that having gum disease has more than just oral consequences. So actually you're doing them a favor in their general health just by doing that.
Yeah. And what about deucravacitinib? What is the use of deucravacitinib in Japan? Is the same of apremilast? Is less?
Yeah. Now still most of the physicians using apremilast rather than deucravacitinib. Yeah, but I'm wondering, I have heard or I read the paper. So non-responder or patients also switch to deucravacitinib. Yeah, but I think the efficacy of deucravacitinib is not so enough, not so satisfied. Yeah, so probably,
if compared to biologic, I suppose.
No, I mean, if apremilast non-responder is not good, even switching to deucravacitinib, efficacy is not good, I feel. So what do you think about that?
Oh, in Italy, the drug, either apremilast and biologics, are on the same level in a way that are completely reimbursed by the government.
No.
Yeah, but the place in therapy is the same. So I can use apremilast only in patients with moderate to severe psoriasis that fail methotrexate, cyclosporine phototherapy, and adalimumab, and adalimumab biosimilar. So the population of patients has a bad psoriasis, let's say. So as a psoriasis that is not responding to methotrexate or contraindication, to other convention, and also to adalimumab biosimilar that is the first line compare apremilast. So my experience with apremilast is frustrating because usually in this setting of population is not working very well. They fail. Because in my mind, the use of apremilast should be anticipated in a population at the earlier stage of psoriasis. Let's say moderate patient, more localized psoriasis. So I suppose that in this setting, apremilast would be more satisfying in terms of efficacy and whatever. In other words, if the patient fail methotrexate, patient fail cyclosporine, phototherapy, and adalimumab biosimilar, I don't go to apremilast. I go to another anti-interleukin that's more powerful.
The only time I use it is if a patient comes on it and wants it. I don't have a problem doing that if they're happy with it, but it is never a first-line choice for me for anything. Also, I will point out for mild to psoriasis, there is no evidence from any oral that clearing mild psoriasis requires less of a drug than clearing moderate psoriasis. Like take cyclosporine. If you want to clear with cyclosporine a mild to moderate, it still takes the 3 to 5 mg per kg dose to do it. I mean, so this whole concept that mild disease requires less of a drug to clear if you're going for clearance, I think is totally false. So the other thing that we don't mention here, which is coming, the phase 2 studies are already published, but deucravacitinib is exciting in cutaneous lupus. It is going to be a versatile drug. I mean, we're going to see, and I think it's very exciting for what happens in cutaneous lupus.
Yeah. So the last comment could be to have your insight in a patient who develop paradoxical reaction with IL-17 inhibitors, like eczema reaction that may happen. In this particular case, in my mind, deucra could be an option because having a more mode of action could inhibit either Th2 and Th1 inflammation. What do you think about that?
Well, we've actually reported these cases and the treatments for them. Actually, a pure JAK inhibitor, I think, is better because deucravacitinib, as you know, the rationale, it inhibits the alpha beta interferons, IL-12 and IL-23. These are not mediators of atopic dermatitis. However, the JAK inhibitors, let's say upadacitinib, for example, has approval for both atopic dermatitis, psoriatic arthritis, we can go on, inflammatory bowel disease, which is an important one too, rheumatoid arthritis. So they are quite effective when somebody is bouncing back because they go back and forth between Th17 and Th2 mediated disease. I have numbers of these patients. If the patient can tolerate a JAK inhibitor, that takes both. Now, in the United States, that's tricky because technically they don't have a psoriasis approval, the JAK inhibitors. All right, so they have a psoriatic, tofacitinib and upadacitinib have a psoriatic arthritis approval. So that probably, for me, it's not a problem. For other people, it may be a problem to try to get those drugs. But in this case, those patients tend to be complicated. They tend to bounce back and forth. And so if they tolerate it and they can afford it, remember it's expensive in the United States to get a upadacitinib or tofacitinib. But I use upadacitinib, has better data. But upa is a good choice in that setting. It's kind of because it's not as selective. It's exactly what you said.
Yeah.
And so, yeah.
So you would prefer upa, let's say JAK inhibitor, compared to deucra?
For that particular situation, yes.
Yeah.
Now, many times, if the patient is elderly, I think it's risky to do a JAK inhibitor, right? I mean, and if they have contraindications to do it, then it's not as pleasant a situation. Then you have.
So I thank you very much. I think that we should summarize the first part of the discussion. And so I think that the bimekizumab is very effective. I think that we share this very rapid, very effective, also in the long term.
Infrequent dosing.
Yeah.
Every 8-week dosing is nice for an
yeah, absolutely. Every week, 8 doses is very nice. And also the efficacy on psoriatic arthritis, possibly also on pre-psoriatic arthritis. That is also an important issue for us of dermatologists, because in some way we could, let's say, prevent the transition from PSO to PSA in this context. So is important the discovery, innovation for our patient. On the other drug, deucra, is very interesting mechanism of action, novel mechanism of action, more effective than apremilast. Although apremilast have in the US a large success because of, let's say, the perception of not being immunosuppressive and very easy to prescribe, not monitoring, that is an added value. And but also the deucra is more effective, so possibly we'll have also the opportunity to enter into the market and have a place in therapy for those patients who prefer oral treatment compared to injection treatment.